My name is Dr. Bob Ryder from Birmingham in the United Kingdom, and I'm delighted that I've been invited to talk to you about the ABCD-DECON collaboration. Many people know me as the principal author of this book published in 1986, and Dr. Dipesh Patel, chairman of ABCD, asked me to include a picture of myself from that era, and this is one such of me examining the eyes of a patient with ocular palsy, and this picture appears in all editions of the book. This is a picture of the Department of Neurology in the University Hospital of Wales at the time when I was writing the book, and you can see me in this picture. But more importantly, the two consultant neurologists, Dr. Charlie Wells and Dr. John Graham, and I mention them because they taught me neurological examination and also inspired me. We must remember that in those days, CT scans, though available, were in very short supply, and only a small number of selected patients could have them, and the waiting list was a matter of weeks. So most neurological diagnoses were made by clinical examination, and it was very impressive to see such clinicians in action. At around the same time, I worked for a cardiologist, Dr. L.G. Davis, who could assess the severity of mitral stenosis by the time in milliseconds between the second heart sound and the opening snap, and he used to estimate that time and mentioned it numerically in his clinical letters. The Royal College of Physicians wishes to preserve such clinical skills, and therefore in the MRCP clinical exam they will always be assessing the ability of candidates to detect and diagnose the heart murmur, the basal crackles in the lung fields, the mass in the abdomen, the brisk reflexes, the upgoing plantar, the visual field defect, the nystagmus, etc., and hence a second edition of the book in 1999. Then after the change to PACES, the third 2-volume edition in 2003, and the monster 3-volume 4th edition in 2013. And turning now to diabetes, there is a worldwide pandemic, as you'll be aware, with the number of cases increasing relentlessly and projected to continue to increase relentlessly into the future. And this is a map of the global diabetes pandemic. And we have many such patients in the United Kingdom, but as indicated here, the numbers in India are colossal. And so a collaboration between ABCD and DECON seems to me to be timely. We have a well-established ABCD nationwide and worldwide audit program, auditing new medications and devices as they move from research into real clinical use is the aim of the program, and often we have found that patients who receive them in real clinical use are different from those in the clinical trials. For example, in both our audits of GLP-1 receptor agonists and SGLT2 inhibitors, the patients were heavier and with worse glycemic control than in the clinical trials. I would like to mention two current ABCD worldwide audits that you could readily join from India, as shown in this slide. The DIY Artificial Pancreas Systems audit. This is based on the hashtag wearenotwaiting movement. Certain blood glucose monitoring sensors send their data to smartphones, and smartphones can be used to control insulin pumps. As a result, various people around the world, clever with technology, have collaborated online to create algorithms to send signals to the insulin pumps based on the current blood glucose and the changes in blood glucose, such that an artificial pancreas setup is created. ABCD is now auditing this type of treatment, and so if you have any such patients, please join the audit. Around the world, there are very many diabetes specialists with just 1 or 2 such patients, and it is the data from all these 1 or 2 such patients added together that will form the output from the audit. The other audit that you could readily join is that of testosterone deficiency in men with type 2 diabetes. Asking about erectile dysfunction should be a part of the routine annual review in all men with diabetes. If present, you should measure the testosterone and, if low, repeat with SHBG, LH and FSH. There's a very high prevalence of this problem. 40% of men with type 2 diabetes have symptomatic testosterone deficiency. Testosterone deficiency is associated with an adverse effect on cardiovascular risk factors, osteoporosis, reduced muscular strength, including frailty, anemia, and reduced psychological well-being. Testosterone deficiency is also associated with an increased mortality in type 2 diabetes and independently in cardiovascular disease. Testosterone replacement has been shown to improve insulin resistance, lower HbA1c, lower cholesterol, reduce body weight, reduce mortality, and the patient feels better. If you'd like to join either or both of these audits, just simply Google ABCD audits. This is the web page of the DIY APS nationwide audit. And this is where to register to join the audit. And this is the page of the testosterone in diabetes audit. This is where you click to join it. It's as simple as that. Finally, we'd like you to consider submitting papers to the British Journal of Diabetes, which is the journal of the Association of British Clinical Diabetologists. We accept papers that follow PubMed criteria as listed on this slide. And this is the page on the BJD website where you can find the PubMed guidance for each type of manuscript, and we're looking for randomized controlled trials, systemic reviews and meta-analysis, case reports, observational studies, indeed almost anything to do with diabetes. And so in our collaboration between ABCD and DECON, which we believe is timely, we invite you to consider joining the ABCD audit programme and also to submit your manuscripts to the British Journal of Diabetes. Thank you for listening.